In the late 90s, the NIH puts out a big study, the Women's Health Initiative study. I think it was 5 years later, they stopped the study early. They put on a press conference. They found that hormone therapy was causing an increased risk of invasive breast cancer and cardiovascular disease, in particular, stroke, heart attack, and pulmonary embolism.
What was the catch on that study that people were missing out on?
So what happened was...
We have Dr. Jila Senemar. All right.
She's not just treating symptoms. As a veteran OB-GYN, she's redefining the future of women's longevity. Get ready to take back your health with Miami's top specialist, Dr. Jila Senemar.
Why are the men getting all of this support on hormone optimization while women are not getting that type of care?
Because you just had a baby, you should be over the moon. Oh my God, you have a baby, you should be great. But she's struggling. Number one, she's not sleeping because she's taking care of the baby. The societal pressure of breastfeeding only. Because if you don't breastfeed 100%, then the baby's gonna be sick. Now put in all those hormonal shifts. I can't be a good enough mom, and then because I'm not doing this, and this that I was told I need to do, which all of that is nonsense.
If someone's heavily drinking, doing drugs, marijuana, cocaine, whatever it is, can they pass that dependency to the baby?
So it all depends on
Welcome to another episode of a Healthy Point of View podcast. I'm your host, Sam Tejada, and as usual, we're bringing experts from all over the world to talk about health, wellness, beauty, and mindset. Today, we're going to go deep on women's health. Not just women's health, though. We're going to talk about how to make super babies and how to actually start your longevity journey before you're even born. How do we do that? We do that with the mom. How do we go ahead and work with the mom to get her to have that healthy baby? Well, we're going to tap into an expert who has over 25 years as an expert in OB-GYN, as a physician, delivering babies, and working with women on their health. The other thing we're going to talk about today is about what Dr. Marty, head of FDA, commissioner of the FDA, has talked about recently in the past few months, the black box warning of hormone optimization with women. So today we have Dr. Jila Senemar. All right. Doc, welcome to a Healthy Point of View podcast.
Thank you for having me here, Sam.
So listen, this is going to be a great podcast to talk about because we're going to go through like that full cycle, right? Life cycle. And you know, one of the things that we always talk about in the world of longevity, when we talk about health span and lifespan, is, well, when is the right time to start? And when we met, we initially met at Mar-a-Lago for the longevity Thanksgiving luncheon. And when we started talking and you told me about your background as OB-GYN, delivering many, many babies, you know, in my opinion, longevity starts when we conceive, right? So I want to tap into that expertise, but before we get into any of that, I want people to get to know who Dr. Jila is, right? And I want to know not about your professional life. I want to know about your upbringing from when you were a kid and what got you where you're at today.
Well, like I said, thank you so much for having me here. And I'm so glad we met at the luncheon because, you know, there's a lot of different ways to go about health and wellness. And there's a lot of different people out there, but you really need to kind of find the right people giving the right information. And I think we're all kind of on the same page in terms of health, well-being, longevity, and all of that. For me, that's come full circle. You know, I'm of Middle Eastern descent, and I was born and raised in the Middle East, Iran, to be specific. And I didn't move to the States until the mid 80s. So I was already older by the time, you know, we migrated to the US. I grew up in California, and I went to school there and, you know, then went on to medical school and trained in New York and ended up in Miami, about 22, 23 years ago. The majority of my career has been spent here in South Florida. But in terms of like upbringing and kind of what got me into this field and, you know, the way how things worked out and my path was kind of, you know, paved in front of me was, you know, coming from that background, everything was very basic. We basically, my mom would make everything herself. There were no restaurants, there was no fast food, there was no chemical changes, things like that in our environment. And we took that for granted, to be honest with you.
Right.
Now fast forward, I'm looking back, I'm like, wait, all the things that my mom was doing for us and the foods that we ate, that's why we were never really sick. And we don't have these epidemics of obesity and, health disorders and things like that back home, because the foods we were eating and their environment was a lot cleaner than kind of what we have here in the, newer world and more, up to date. So there's pluses and negatives, I guess,
Right.
is the way you have to look at it. But a lot of that kind of pushed me into looking at women's health from a different lens. It wasn't just about doing the surgeries and delivering the babies, but it was deeper. It was kind of like what was going on with the woman prior to
Right.
conception. And like you said, women's health really begins at the time of conception in the womb. And that's kind of where we need to set the stage in terms of women's health and to treat them well and appropriately. So it starts really from the time that they're born to when they go through puberty, then when they go through their fertility journey into perimenopause, menopause, and beyond. A lot of women's health has been done in silos. It's like you have the box of puberty, and then you have the box of birth control, and then you have fertility here, and then menopause is somewhere over there.
Right.
And it's done separately and kind of broken up. And that isn't the way women's health should be. And that's not the way a female body, their biology is. It's more of a spectrum, and you need to start on one end of it and then kind of follow the journey all the way through. So that's where my career started, and I started seeing the changes even in conventional medicine. And that's where I was like, okay, you know what? This was about 5, 6 years ago, right around the time of COVID, where I was like, I need to do things differently. Things are changing. We're not really helping women the way we should be after they're done with their reproductive years.
Right.
We're dropping the ball. Like, it's kind of like, oh, yeah, you're going through the change. Kind of, too bad. There's really not much we can do, and let's move on. And I knew that wasn't appropriate. I don't like not having an answer for my patients, and that was one of the first times I was like, I don't really know what to do here. Um, and then that kind of goes back to what happened back in 2002. I was actually in training when the Women's Health Initiative study was released.
Mm.
Okay.
That's when that black box warning came out.
Everything
Right.
came out then. So in the late 90s, they decided to remember, but number one, women weren't involved in studies or recruited for studies until 1993.
Wow.
So let's let that sink in.
Yeah.
That was just like yesterday to
That
me,
was just right around the corner.
right
Yeah.
before, right? I remember where I was. I was in college. Like that's how,
Yeah.
recent it is. So now they decide the NIH puts out a big study that they want to do. It's a prospective, randomized, double blind. So it's the gold standard of
Right.
studies. The Women's Health Initiative study was put together to look at prospectively women and hormone therapy and if it can help prevent chronic long-term disease in aging women. That
Mm.
was the primary goal of the study.
Okay.
5 years, I think it was 5 years later, they stopped the study early. They put on a press conference, and this is before, internet and things like that. So the other researchers, people did not have access to the actual paper and the results.
Okay.
So only a subset of researchers got together and came up with the press release. Not everybody was involved in it. Okay. So they go to this press release, and the thing that they say is that they had to stop the study early because they found that hormone therapy was causing an increased risk of invasive breast cancer and cardiovascular disease, in particular, stroke, heart attack, and pulmonary embolism. Those were the results that they released in the press release. And overnight, that fear caused a tremendous drop in the number of prescriptions that were being written and or filled by women for hormone therapy.
So what was the catch on that study that people were missing out on?
So what happened was when the actual study was released, like 8 days later, it was published in JAMA, and all the scientists started reading, and they're like, hold on, that isn't what they said. the numbers that were quoted were not strong. They were not statistically significant in that study.
Oh, wow.
Okay. Fast forward to now, 23 years later, a lot of those claims of that press release have all been rescinded by the Women's Health Initiative, but there were no press releases to say that.
Wow.
Okay.
Wow.
One of the biggest things we know today, which again, we've known this, it's just, now it's out, is that in the arm where the women only received estrogen, the amount or the number of cases of breast cancer actually declined.
Mm.
No one talks about that.
Wow.
We don't have that data. So a lot of harm was done. That is the bottom line with the WHS. A lot of harm was done to a whole generation of women who didn't get the benefits of these hormones, and hence the risk of heart disease, bone disease, fracture, and dementia rose. And now here we are 20 some years later trying to reverse all of that.
Wow. Would you say that proper hormone optimization in women can help avoid things like osteoporosis?
Well, that is the number one reason for treatment with hormone therapy is the prevention of
Right.
osteoporosis. That data we have, it's clear and it's supported by American College of OB-GYN, by the Menopause Society, by everybody.
Yeah.
So what Dr. McCary did, which is monumental for women's health, a lot of us have been doing the work. We have been treating patients at least more recently now, because even with the FDA's black box warning on, because we know better, we know the research, and that's kind of the conversation we were having with our patients. There are doctors who have been around that are in the field, and they were there before the Women's Health Initiative, and they've been there since, and they never stopped treating women
Right.
with hormone therapy. They
Yeah.
knew, they read the study, they understood it, and they explained it to their patients. But again, it wasn't a global thing.
Yeah. And when you look at the masses specifically, like, obviously I worked in the fire department for 12 years from the age of 20 to 32. I retired. I'm 39 this month. So, 7 years ago, I retired. But when I was working at the fire department, my part-time gig, I was working in functional medicine with Dr. Robert Willix. And that was around 2005 is when I got in. And they were one of the pioneers in hormone optimization. And throughout the years, I saw a huge disconnect between how men were getting treated for hormone optimization versus the women that were going into these hormone optimization programs. They weren't being supported the same way how men were. And this was for years and years, over a decade, I saw it. So why such huge difference between both? Why are the men getting all of this support on hormone optimization while women that truly have a huge influx in hormones are not getting that type of care?
So that's actually multifold, that question, because women, number one, like we talked about, we're not part of research studies. So that just kind of puts it where it's at in terms of women's health. We're very far behind. Okay. So number one, we weren't part of research studies. Number two, doctors, once the WHI came out, there was minimal training on hormone therapy for peri and menopausal women. So here we are in residency. We're supposed to be taught all of this. Now they're like, yeah, you don't need to learn this. There's nothing there to do. It causes cancer. It's bad. Don't worry about it. That was literally the type of trainings we were getting.
All right.
Okay, so we are the new generation of doctors coming out. I'm speaking for myself, as well as a lot of the trailblazers in this space today. We're all part of that same generation where we're like, no, now we know better, so we're bringing it back. So the pendulum in medicine always swings from one extreme to the other. And so we're kind of bringing it center right now with the fact that we have the research, we have the data now, and now we have the FDA behind us supporting. The reason the 10 years you were working at the prior office was because there's fear. You still have this fear in the back of your mind. What if I
Right.
give this to her and she gets cancer?
Right.
Okay. And that can happen. But did it cause it? Probably not. If anything, there was an underlying issue there. Now, stimulating her with hormone therapy brought this problem to the surface earlier rather than later.
Right.
Because if you really look at it physiologically, we have hormones in our body from the time we're born. In pregnancy, that is our highest risk of getting any kind of disease, is because that's the highest point of estrogen and progesterone,
Right.
right? So why are pregnant women coming out with cancers?
Mm.
That's not that isn't the pathophysiology of what happens with hormone therapy. Somebody who has a precancerous cell, that cell is in their body. It
Right.
just takes something to initiate it.
Right. Right.
So hormone therapy does not cause breast cancer. We all know that. But if somebody is predisposed to it, yes, they're at higher risk. So the conversation then changes. It doesn't become, no, you cannot take it. It becomes, these are your risks and these are your benefits. And this is how we're going to address you going forward.
Right. Yeah. No,
That's it.
I like that. Dr. Jila, so before we go further into women's health, adult women's
Mm-hmm.
health, right, hormone optimization, I want to go way back in time,
Mm-hmm.
right, to creating these super babies,
Mm-hmm.
right? So I want to go through before having a baby, then the baby being born. We'll talk about a few things about
Mm-hmm.
what's happening when babies are born, and then we're going to go into the puberty, right?
Mm-hmm.
We'll talk about some of the things that are happening with birth control and all this stuff and messing
Mm-hmm.
up people's hormones,
Mm-hmm.
and then go into the rest,
Yeah.
perimenopause, menopause. Um, so I have a lot of appreciation for people who deliver babies. I've gotten to deliver quite a few babies myself
Mm-hmm.
working in the fire department.
Right.
Unique scenery where I deliver the babies. Because a lot of people think, oh, well, it's in the back of the truck. It's like a lot of times it's not in the back
It's
of the truck.
not.
It's in a bathroom stall.
Right.
Sometimes it's on the side of I-95 of the
Mm-hmm.
freeway. Sometimes, the babies we deliver are very sick babies,
Right.
babies from drug addicts. And
Mm-hmm.
then we have the people that love having babies and not going to the hospital. They want to have them at home inside of a little tub or
Tub.
pool. So you see it all.
Mm-hmm.
And, delivering babies, when I first got into the fire department, it was very nerve wracking. It was just like I
Mm-hmm.
would freeze. And I remember when I started at the fire department, my probation year, I had one of the lieutenants, one of the rescue lieutenants, came up to me and says, Sam, this is the most natural thing. Humans are the only ones who actually go to a hospital to have babies.
Right.
And it clicked, and I was just like, right.
Yeah.
It's like,
Yeah.
why am I so worked up? Like, I have my training, all my medical
Mm-hmm.
training and stuff, but just let it happen and be there as an arm of support. So, I just wanted to say that because that
Yeah.
always clicks when I hear about delivering
Mm-hmm.
babies. It's the most natural thing. But in your career, how many babies do you think you've delivered?
It's funny. We actually did the numbers just a
Oh,
few
you
years
did?
back. Yeah, just for fun, just to kind of see, and it came out about 5,500 or so plus.
Wow.
Yeah. Mm-hmm.
That's crazy. That's a
Yeah.
lot.
Yeah. It was quite an
Wow.
accomplishment, and it's funny because I started delivering babies in 1999.
1999, right before the
1999,
millennium. All
right
right.
before, and a lot of those kids are my patients.
Oh, really?
So they're grown up and they become patients of mine. So that really puts it in perspective, right? When I think about that, and I'm like, yeah, that makes sense because my oldest is 22, and I had him when I was in training as well. So
Wow.
yeah,
Wow.
makes sense. Yeah.
Man, so you've seen a lot.
Mm-hmm.
55 babies.
Mm-hmm.
So with your experience delivering
Mm-hmm.
55 babies, and it's probably been a mixture of, doing the C-sections,
C-section,
natural,
vag.
and all that stuff. You've probably seen mothers living different type of lifestyles and their babies having different type of complications,
Mm-hmm.
right? So, and especially if a lot of these babies are your patients now,
Right.
you could probably see things that have worked up to where they're at with their health
Mm-hmm.
today. So I want to talk about creating that super baby. What does the mother have to do to prepare to have a very healthy baby?
Yeah, that is a great question because things have shifted and changed over the years. Even over my career, I can tell you back in the 90s, early 2000s, environmentally, we may have not been that far off in terms of hormone disruptors and things like that. Fast forward to today, I think we're not in a good place. I think environmentally, there's a lot going on. And so we really need to pay attention to what we eat, our food, the sources, and things like that. So for my patients, a lot of it would start before they would consider conceiving. And it would start with lifestyle modifications. What are you eating? How are you eating? Are you exercising? It's not all about taking a pill or a multivitamin or a prenatal. It's really lifestyle, chronic stress on the body, because all of those things go into play to make sure that you have a healthy ovary ovulating and releasing that healthy egg, as well as the partner and the sperm being a healthy sperm. That way you have the optimized baby
Right.
at that point. So it was about making sure all of those, boxes were checked off with each individual patient. So I would do prenatal visits. I would do a preconception appointment with both partners
Oh, okay.
and kind of go over all of this with them. And then once they conceived, we'd see them quite a bit, actually, especially at the beginning. It's every 2 to 3 weeks that we see them to make sure they're getting all their testing done, pre-genetic testing, genetic testing, all those kinds of things, optimizing iron levels, things like that, that
Right.
all go into effect, optimizing the thyroid, because that has a major impact on the baby's brain development.
Mm.
So there was a lot going on. And so, pregnancy is one part of it, but it's kind of, what do you do during the pregnancy? How are you optimizing yourself? Are you sleeping well? Are you eating all the right foods? Because as you know, in pregnancy, women have aversions.
Yeah.
So what they used to like, they don't like anymore. And then they have these crazy cravings. And it was all about moderation. I would tell them, listen, you can have certain things, but don't go eating ice cream all day long. Okay,
Right,
I
right.
realize you have a craving for it, but let's put that in balance.
Right.
Women are checked for diabetes throughout the pregnancy to make sure they don't develop gestational diabetes. So those were the key factors we really employ during a pregnancy to assure that you have the best possible outcome. Now, even with all of that, there are times things don't go as well as we would expect.
Okay.
And you have, a surprise, but it's less and less over my career because we have so much more testing, non-invasive testing that can be done ahead of time to prepare ourselves for if anything there's going to be a problem or not.
Absolutely. So let me ask you this. We live in South Florida.
Mhm.
It's the red zone for a lot of different vices,
Mhm.
alcohol,
Mhm.
drugs. People are medical marijuana. People are smoking
Mhm.
marijuana. People are doing all kinds of stuff. We live in a very toxic world alongside with that. So before actually conceiving, these vices
Mhm.
in I don't know the answer to this, right? So what I'm asking you is, like, if someone's heavily drinking
Mhm.
for many years, can they pass that dependency to the baby if they don't clean themselves up? If people are doing drugs,
Mhm.
marijuana, cocaine,
Mhm.
whatever it is, can they pass any of this stuff on to the baby, even if they stop, when
Mhm.
they find out they're pregnant?
So it all depends on, number one, the amount and what exactly we're talking. Alcohol in and of its own, unless somebody is an alcoholic, then yes, the baby is at a higher risk of developing that, not directly, just by genetics, basically.
Okay.
Okay. Now, if somebody's, let's say there's a couple and they're having difficulty conceiving, then that would come into play because maybe the increased amount of alcohol intake is affecting sperm quality or even egg quality for that matter. So those
Right.
all have to be addressed, okay, because they can affect the pregnancy negatively.
Right.
Drugs, 100%. So we, luckily in the practice that I was at, we didn't have those kinds of patients, but I did work at the University of Miami at Jackson. So I did see quite a number of moms who were still on drugs throughout their pregnancy
Throughout the pregnancy.
yeah. So
Oh my
again, you
God.
see all different
Yeah,
kinds
yeah,
of
yeah, of course.
patients. Um, and that does cross right over to baby, and the baby
Right.
is born with withdrawal symptoms of
Oh boy.
cocaine or whatever have you. Marijuana, less so, but nonetheless, it still does have an impact on the baby's brain development and even growth restriction
Right.
problems. So they don't grow as well, and they don't thrive as well even when they're born. So there's a lot of different components, and yes, they do definitely play into it. It's just a matter of, is it just recreational, and is it just a couple that they just had some fun, and then all of a sudden they found out they're pregnant, and now they're panicking, that is not going to be much of an issue going forward. And I always kind of joke with them. I said, as long as you don't keep smoking and drinking, I think we'll be okay. But in general, most people nowadays, especially, they're having babies later and later. So they're really tuned in to how they can optimize themselves prior to conceiving. That way, none of this happens.
Absolutely. So, okay, so we talked about different things that they could do lifestyle
Hmm.
wise, right? We talked about some of the toxic stuff we're exposed to and how to minimize that, detox it as well. Especially any of these vices. Now, baby's born,
Hmm.
right? One of the things that just came out on the news is about all of these vaccines that are being injected to the baby,
Hmm.
which you delivering babies, which
Hmm.
congratulations on the amount that you've done. And I know I spoke to you
Hmm.
on the phone a few weeks ago, and it
Right.
was your last delivery,
Right.
so that was
Hmm.
amazing. Um, the vaccines.
Hmm.
This is a topic that some people are a little bit nervous to talk about,
Hmm.
but we're going to talk about it
Yeah.
today. So, you hear the Trump administration talk about these 72 jabs that kids are being,
Hmm.
once they're born, they're getting stuck with all these vaccines. What's your opinion on all of this that's developing, the stories that are
Hmm.
developing around that?
So we have to be careful with what we do and how we approach this, this new topic that's coming out. So vaccinations, we know, save lives. That's the bottom line.
Right.
We know that. They've been around forever. We have lots of old vaccines that have been around. They have been studied, they've been tested, and we know that there is proof that they work. And so we need to continue using them. Now, what's been happening is there's certain vaccination protocols, like let's say hepatitis B, which we know is is a blood transferred type of virus, and babies get the first injection of that as soon as they're born in the hospital.
Mm.
And there's 3 doses in this series, so they get the first one in the hospital, and then they follow up with their pediatrician for dose 2 and dose 3. According to the American College of OB-GYN, this is standard protocol. Now, if you really break it down and really get into the nitty-gritty of it, if the mother has already been tested 2 or 3 times throughout the pregnancy for hepatitis B, we know she doesn't have it.
Right.
Yet, here we are, jabbing this baby right when they're born. Like, is it really critical at that point? And so a lot of what's happened now is we're listening, we're shifting, we're changing, we're thinking outside of the box a little
Right.
bit with reason. Okay? And so a lot of parents are opting to wait for that first dose to be done with their healthcare provider, their pediatrician. So that's number one. A lot of other things that we do is during pregnancy is preventative to make sure mom gives some passive immunity to baby, because babies do not have a fully mature immune system until 3 to 6 months of age.
Right.
Okay, so we do recommend the Tdap vaccine, which has been studied. It is not a live vaccine, and it helps boost mom's immune system to kind of give passive immunity to baby. The other ones are the flu vaccine, which has been studied again. None of these are live vaccinations. And there's data behind the flu vaccine, especially in the flu season, because mom can get quite sick.
Right.
And that can end her up with pulmonary complications in the ICU and things like that. And it can even lead to preterm delivery. So you kind of want to be careful with those. Now, in terms of what just happened with the vaccination protocols that they're recommending, is we have so many vaccines we're giving kids, especially for school attendance and things like that. And a lot of our vaccines are like one injection is 4 different viruses that we're giving these kids.
Wow.
So what they're talking about is in Denmark, they've done a study and it has shown giving less doses, less vaccinations, and they're actually healthier going forward. So they want to take that model and implement it here in the States.
What's your professional opinion on that?
I think it can go either direction, but to be honest with you, Denmark, I think, is a lot healthier than we are as a nation here in the US.
Right.
And their environmental background is different than ours. So I don't know if that's really going to be plausible here in the US.
Yeah, you're really not comparing apples to apples.
No,
Exactly,
it's
right?
not. It's,
Yeah.
now let's say, European countries, they're different than we are.
Right.
Okay. Now compare US maybe to Canada or something like that. We may be on a different, we may be closer, but the US is very unique in how, we are kind of like we have different pockets
Right.
of theories on things. And so
Yeah.
some pediatricians are like, if you don't do these vaccinations, you can't be a patient here.
Wow.
And then you have others who are more reasonable. And what I really always recommend to my patients is find a pediatrician that is willing to work with you. You're not saying you're not going to vaccinate your child. You're just going to say, I'd like to do it, but within reason. And I don't want to give 4 doses at the same time. Can we spread them out a little bit?
Yeah.
Okay.
Yeah.
Just, and really give me what's 100% necessary and what's like 80% necessary. And then let me decide. I think a lot of healthcare has gone where it's not paternalistic anymore. It's not that. It's like, I don't get to tell you what to do because I'm the doctor. We're past that
Right.
point. Everybody has access to education and information. So we should be able to have a educated conversation about the health of you and your child.
Yeah. It has to be a little bit more of a collaborative type of treatment,
Conversation,
right?
exactly.
Yeah.
Yeah.
I agree with that.
Hmm.
So now we're talking about the vaccination, right? Mom had baby.
Hmm.
So mom has a baby. Now she's going through postpartum,
Hmm.
which now she's experiencing all of this big hormonal shift. What is mom going through?
Yeah. That is one of the pivotal times in a woman's life, honestly. And again, I'm going to preface this by saying a lot of women's health is misunderstood and undertreated because we just don't talk about it.
And a lot of women, they never go back.
Yeah.
After they go have that postpartum and all those issues with the hormone shift, it's just like it's almost like they fell off the deep end.
Mhm.
And it's just like they're just searching to figure out how to get back to where they were at before.
Because it's a taboo, Sam. We don't talk about this stuff because it's not supposed to be happening. You just had a baby. You should be over the moon. Oh my God, you have a baby. You should be great. Yeah, but she's struggling. Number one, she's not sleeping because she's taking care of the baby. And then there's the societal pressure of breastfeeding only. Because if you don't breastfeed 100%, then the baby's going to be sick and you're not being a good mom.
Right, right.
Okay. Now put in all those hormonal shifts. And what that does is plays with the brain. So then there comes the baby blues where they start feeling not adequate as a mother.
Right.
So here's this miracle baby that I wanted. Now I have my child. I can't be a good enough mom. And then because I'm not doing this, this, and this that I was told I need to do, which all of that is nonsense.
Hmm.
You need to do what works for you.
Right.
You are a different kind of mom than you, and I'm a different kind of mother than somebody else was. But we were all great mothers in and of our own way.
Right.
But all these hormone shifts are happening. No one knows it's happening. She doesn't even pay attention to realize that's what it is. And that's why they have these crazy thoughts and they think something's bad's going to happen to the baby. So they're just watching over the baby. And then that can evolve. Baby blues can, if not addressed appropriately, it can evolve into postpartum depression, which
Mm.
again, if that isn't addressed or picked up on, then it goes into postpartum psychosis. And those are the bad stories that you hear about. Luckily, we have moved the needle on postpartum where now we are seeing patients a lot sooner in the office after they deliver so they can't fall through the cracks.
What's that term? Postpartum psychosis? you said?
Psychosis. So it's baby blues,
Okay.
and then it turns into postpartum depression, which is quite serious. And from there, it goes into psychosis, where again, they lose touch with reality
Yeah.
and they harm themselves or the baby or both.
Yeah. And I've heard of cases like that, and
Mhm.
where some of the mothers won't even look at the baby.
Mhm.
You know, it's almost
Yeah.
like they have this like,
Negative
yeah,
relationship with the
right,
baby
right,
because they feel that they lost a sense of themselves
right.
because of that. But to help bridge this gap of not understanding, women are being addressed right in the hospital after delivery.
That's
So
good.
they're being screened right off the bat.
Right.
So then if we have an alert that, hey, something's off here, we keep an eye on them. We have a specialist see them in the hospital and provide assistance. Then they're followed at home with phone calls and talking to a specialist and making sure they have family support. because that's
Yeah.
where it's at. I can only be with them for so long. It's whoever's with them at home. Are they providing that? So do they understand what's going on?
Now, when they go through this, these issues
Hmm.
postpartum, is this a hormonal issue, micronutrients deficiency issue, or all of the above?
All of the above. Majority of it is hormonal fluctuations, which then play into the next stage of a woman's life, which is perimenopause and menopause. So a lot of what I'm seeing now is women are having children later. So, and what I used to mean by that was around 30, 35. Now that's moved to 40s.
Wow.
Okay. Because again, I think it's just the world is changing and shifting, and people are they just
Yeah.
want to be more established before they have a baby. And so they're being more responsible, I think. And so they're putting their careers and things like that ahead. And so they're not really getting pregnant until they're like 40, 42. So they have the baby. And a lot of the stressor of the pregnancy can actually push them into perimenopause,
Okay.
unbeknownst to them. So these hormonal shifts definitely play a role in the psyche, and we know progesterone has a calming effect overall. And we don't have that much progesterone postpartum. We have more estrogen, which makes you more labile.
Mm.
So it's those fluctuations. So by seeing the patients more and discussing these things with them, it actually helps them understand their own biology, and then they can tune into it.
Right.
And then we have therapists they call and they check on the patient weekly as needed. And then there's other medications now that we have that are literally just for postpartum depression. It's a short course of a medication, and it helps smooth these hormonal changes.
Now, do you do any hormone optimization, any like bioidentical hormones during that time,
Mhm.
or create any other kind of program for
For
them
them.
with different vitamins, supplements, etc.?
So we make sure that hormone optimization, really, you can't do much in postpartum, especially if they're breastfeeding,
Right.
because it has an impact on the breast milk production. So that like if somebody isn't, then yes, we can do some manipulation to kind of stabilize the hormone
Right.
fluctuations, and they feel better. Optimization of vitamins B6, B12, all of those. Vitamin D3, we know it helps with mood, immune, all of that. So a lot of those have to be played into it. So we make sure that they're optimized there. Sleep is a big factor
Oh
because,
yeah.
again, newborn baby doing everything you're supposed to be doing, and they're not sleeping. So we have to make sure the husband or the partner or family members are on board to help support her so she gets adequate sleep at night, so then she can function better in the next day. Um, Moving past that postpartum window, when they're thrown into the full-blown perimenopause chaos, then yes, hormone optimization is definitely key there, because you can just kind of, it's optimization, it's not replacement, you're optimizing it.
Right.
So you kind of see, what are we missing, what's not working, okay, let's just kind of fix a little bit here and there, and within weeks they can start to feel like themselves
Yeah.
again.
And you mentioned, vitamin D3, the
Hmm.
importance of that and how it helps upregulate hormones, immune
Hmm.
system, etc. And you talked about sleep,
Hmm.
which, sleep obviously helps us upregulate our hormones and balance things out. It helps us recover. Um, what about other lifestyle habits?
Hmm.
For example, exercising or other type of nutrition, things that meditation,
Hmm.
etc.
So when women are going through a lot of these hormonal shifts, what happens is cortisol then starts to rise too, which is our
Stress,
inflammatory
yeah.
marker. Yeah, stress. And that cortisol rising can then lead to inflammation all across the body, all across the cells. And then that throws off the sleep cycle as well. So they're
Yeah.
all kind of related. The best way to kind of control all of that, meditation is one thing. People don't give it the credit it deserves, because I think, you've just seen it out there for the yogis meditate and this and that, but they don't pay attention to it. But when you actually focus and actually do it and go within yourself and kind of calm your nervous system down, it actually works.
Yeah.
It works like a charm. And so we have to get people more back into that. So I do talk a lot to my patients about putting in these, critical lifestyle modifications to help. And over time, they actually see the value in it. Right away, they think I'm a little off, and they're like, "Are you sure, doc?" I'm like, "Yes.
Yeah.
Just give me a couple of weeks and let's try this out." So it's by meditation. movement. Movement is magical. It's key. Listen, every morning, technically, you're supposed to get up and go outside and ground yourself. What does
Right.
that mean? It just means to go out in the sunlight and stand in the, in the grass. Things that we take for granted. Again,
Yeah.
we're in this you know, fast forward world that we live in. It's like go, 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 chronic stress on us all the time. And this is why self-care, slowing down, taking it easy, these things are so important because they've fallen by the wayside,
Yeah. Yeah.
right?
I'm happy that you're bringing that up because, you know, one of the things you mentioned is the cortisol, your stress
Mm-hmm.
hormone, and that disrupting your sleep patterns, and now your circadian rhythm is completely off. You got a lot of extra stress, which we
Mm-hmm.
all know stress is a true killer, regardless if it's good stress or bad stress.
Mm-hmm.
It's gonna kill you. So making the effort to be able to get your body balanced
Mm-hmm.
is what's going to really help you recover, especially postpartum, and you know when you're going through these different things and getting your body back into that homeostasis, if you
Mm-hmm.
will. So, all right, so we're going postpartum, but before we get into like
Mm-hmm.
perimenopause or menopause, I'm going to go back a little bit
Mm-hmm.
and go into the teenage
Yeah.
years of a woman,
Mm-hmm.
right? Those teenage years when they're going through puberty, there's a lot that's happening, right? There's a lot that's happening with the hormones. And then I remember when I was in high school, they were handing out birth control like it was candy.
Mm-hmm.
I mean, literally,
Yeah.
you saw the girls just with a little
Mm-hmm.
pop out a little aluminum packet. And I'm just thinking to myself, not then when I'm in high school, because I really don't know much
Right.
in the medical field. But now looking back, it's just like, were these people even being regulated? Was anyone even doing blood work or anything? They're just
Mm-hmm.
handing these things out, and this is actually disrupting their hormones,
Mm-hmm.
right?
Mm-hmm.
So I want to talk about these. There are certain women that go through these very heavy menstrual cycles that have all these type of issues, and you know they basically can't live when they're going through the menstrual cycle. So are there a few women that really need to be on
Yeah.
these birth control pills to be able to live their day to day life? Yeah, absolutely. But does everyone need to start taking this at such a young age? Is my
Right.
question to you.
And I'm glad we're going there because again, conventional medicine has taught us to be reactive and not, you know, proactive. Like we should be really more preventative than treat disease, right? I used to see a ton of young patients, adolescents, brought to me for different reasons by their moms. And it was always about she's having heavy periods, so it's affecting her schoolwork because, she doesn't feel well. So she calls me to come home, and this is happening every month. And now her grades are dropping. So that was number one. She's having bad cramps where she needs to be picked up again. It was affecting daily life.
Right.
Then there are those who they wouldn't get their periods at all and they didn't know what was going on. So there was a PCOS picture going on there. And the next one would be just plain out contraception. She's fine, everything's good, but now she's becoming sexually active. And so that's what we're here for. So, being an OB-GYN, and this is what I've done for so long, it used to be reactive. Yes, okay, birth control pill. And guess what, Sam? It did fix all of that. It would give them birth control, it would give them protection so they weren't getting pregnant when
Right.
they weren't ready. It would provide control of the cycle so they weren't having those heavy periods. And so they weren't calling mom to go home and they were doing their schoolwork. And it would help with the cramps as well. The PCOS part, that's the problem right there, is because we were suppressing what was happening there and we weren't really getting to the root cause of the problem.
Mm.
Okay. These are young girls. The hypothalamic pituitary axis, which is the cycle that sends signals to the ovary to tell it what to do, hasn't matured yet.
Mm.
It takes time. It doesn't really mature in a lot of girls until they're in their 20s. Yet here we have a 12, 14-year-old that has been on birth control pill, suppress her ovulation, which is a natural thing that should be happening every month anyway. And now she's 25 years old. She comes off the pill and it's a 50-50 shot. Maybe she'll get her periods regularly. Maybe she won't.
All right.
Okay. PCOS is not just an estrogen issue. It's a combination. It's metabolic. it's inflammatory, it's estrogen mediated. And unless we kind of look at that early on and address it, you're just band-aiding the problem, which will come up later when now she's trying to have a baby and it's going to cause fertility issues.
Right.
Okay. So did the pill cause a fertility issue? Not directly, but indirectly, yes. It just kind of covered it up. And now you're uncovering it. And now you have to deal with it. Where if you back up and you educate the mom and you educate the daughter at a younger age, when they first come in and say, this is a metabolic problem, we need to fix that first, and then your cycles will regulate themselves, they would be at a much better place than just
Right.
handing out the birth control pill, which is the easy solution. So even I have changed my mindset on how to treat these younger patients. I do diet modification. I do supplementation with certain supplements that really work for PCOS patients. And guess what? Within 6 months to a year, they're having regular cycles.
Oh, wow.
It
Yeah.
reverses it because it's metabolic. We know this. It's just kind of like using GLP-1s in the other subset of patients. It's fixing an inflammatory response.
Right.
So we need to be more root cause based rather than just treating a symptom and moving on
Yeah.
because it's easier.
Root cause medicine.
Root cause, that's
that
where it's
is the
at.
future. That's where we need to be. So, Doc, but now you were talking about when they hit like
Mm-hmm.
25, those years of where they're ready to have a baby.
Mm-hmm.
Right now, we're at like the ultimate high for infertility.
Yeah. Yeah.
Why is that?
Why? It's because we're not doing the root cause analysis when they're younger. So, and also environmental. So I always keep saying that, but because it's real. Okay. So you have the microplastics and everything, and there's skincare that they're using. All these 10-step skincare routines that young girls are buying and spending money
The
on,
body's absorbing all this.
absorbing all of it. And these
Yeah.
are all hormone disruptors. We know all of this now. Even their cosmetics, their makeup is not clean.
Wow.
Okay, so this is affecting them. UV light outside. They're on blue screens all day long. They're scrolling nonstop. All of this affects them on a cellular level, and they're not paying attention to it. So that's where we're seeing more infertility at even younger ages. Infertility after 40, 45, it's expected because that egg quality isn't the same.
Right.
But infertility in a 30-year-old, that's not okay. And that's more, getting to the root of what's
Yeah.
been happening to them.
Now, 25 plus years as an OB-GYN, right?
Mhm.
And 5,500 babies.
Mhm.
25 years to begin with. You have the ability to really see what has been happening. How big has the IVF industry grown in those 25 years?
It has skyrocketed, Sam, and
Right.
it keeps going. It keeps expanding because there is a need for it, because we're messing up earlier and earlier. I
But
think
the
is what's happening.
infertility is not only even women. Like
No, no,
I'm
no. It's
seeing
both. It's
guys
both.
in the early 20s.
Correct. Having issues.
They're going to their urologist
Mhm.
and their sperm quality is horrible.
Horrible.
No
Yeah.
mobility, nothing.
Yeah.
So what would be the biggest contributor in your opinion with the 25 years that
Mhm.
you've had and been able to see certain things? What do you think the biggest contributor to infertility is for both male and females?
I think it's a combination of a few things, but it's number one, it's our environmental toxins that we're exposed to so much,
Yeah.
more so now than before. I think it's also alcohol, the potency of the recreational drugs that they're playing around with. It's they're clinics, offices to get CBD, pot, whatever, THC, anything you want, all over the place now in every corner, and it's medical.
Yeah, and it's not even the weed or
No,
marijuana, should I say,
right.
from back in the day, right?
It's
This is
there's
like
other things in
it's
there.
like supercharged. It's like
Correct.
this thing here, this will make you better. It's like,
Yeah.
whoa.
No,
Well,
we don't even know what, it's not even pure anymore.
it's chemicals.
Chemicals,
Yeah.
vaping, all of these things.
Yeah.
And then now add chronic stress that these younger generations have, right? To keep up, not sleeping well, not moving, not exercising. That all plays into what's happening in the, looking forward.
Right.
But what I can tell you, which is very optimistic and it's good, they're seeing the difference. and they are reversing it themselves. So the younger college kids now, they're actually not drinking as much as they used to.
Yeah, I keep on reading a lot about that.
They're not
Yeah,
drinking that much.
they're becoming aware.
Aware because of people like Brian Johnson and things
Mm-hmm.
like that out there. Like my 22-year-old's like, I want to get the Brian Johnson things. I'm like, okay, but Brian Johnson is trying to become your genetics, so you don't need that. Just
Right.
continue doing what you're doing.
Yeah, yeah,
But that, I think that's what's getting them to be more conscious of what's going on.
yeah, yeah. Which is a good thing. I like that. You
We
know,
want
you
that.
just got to keep on spreading it. You know,
Correct.
that's what we do on like podcasts like this. Really try to get that information out there. All right, so we started working with the teenagers. You know, they're going through puberty. We talked about the BCPs, the birth control pills. Now let's go into the perimenopause. What are people experiencing? What are women experiencing? Oh,
Well, no,
not
I
ju-
think it's people. I think it's both. It's men and women.
Yeah, I was just gonna say not
Yeah.
just women. Actually,
Yeah.
what are men and women experiencing throughout
And
that
yeah.
perimenopause?
It's so the way I explain to, to the community is it's kind of like that spectrum of hormonal fluctuation. So you had the beginning, when in puberty, where it was like your hormones were all over the place. Then they kind of calmed down in the next, 20 years. And now they're back up being chaotic again. The problem is everybody has been focusing on periods and hot flashes. So, but you have regular periods and you don't have hot flashes, then you're not there. So we're missing the boat.
Mm.
Where the body is sending little signals throughout this phase. And perimenopause can last upwards of 7 to 10 years. And it can start as early as mid to late 30s.
Right.
And menopause is until 51. So you have that whole 30s, 40s where this fluctuation could be happening. And the woman is looking for period irregularities, which may or may not happen. So the other signals that should be aware of and pay attention to is sleep disturbances. That's where it starts popping up, and mood changes.
When you say sleep disturbances, is it just like waking up at night, or like waking up sweating and having the hot flashes?
Could be any of the above.
Any of the above.
It could be
Okay.
they fall asleep fine, but they wake up at 2 or 3 in the morning every night and they don't know why. It could be that they go to sleep, they wake up, they fall asleep, but they wake up unrested
Right.
because they're not having deep quality sleep. It could be that they don't fall asleep at all, but once they're finally asleep at 4 a.m., then they sleep well. So it's any of those variations. And it doesn't have to be every night. It could be like 2 to 3 nights a week
Right.
over a couple of months, but that is considered a sleep disturbance. The emotional part is what really gets a lot of women because, women around their periods, they're granted, they have hormonal changes, they're used to that. This is on a different level,
What level is it on?
meaning it's more generalized to everyone and everything. They just don't have that, the patience anymore. Where moms are running around doing 50,000 things. All of a sudden now she can't stand certain things. Or I don't know if you've seen these memes all over social media. It's like, I just can't stand the sound of him chewing.
Yeah.
And it's like, okay, but he's been chewing like that forever.
Yeah.
Why is it bothering
It's
you
almost
now?
like they're just walking around cranky.
Cranky.
Yeah.
They're just cranky. They're not themselves. And I have women come to me and they're like, something's wrong. I'm not myself. And I know, and they can tell. They're like, something's off. I don't know what it is, but this isn't my baseline. The partners are now becoming more well versed because of these conversations happening, and they're like, that's what it is. Before they're just like, she's just crazy.
The partners are diagnosing.
They're
it.
like, I have partners bringing in the wives.
Yeah,
They're
yeah.
like, I think she's in perimenopause, and I told her she needs to come see you. But the conversation needs to go both ways
Right.
because it affects the whole unit. It affects the partner, it affects the kids, it affects work, it affects family and friends.
Oh yeah. Yeah.
And-
I mean, a lot of these things, when someone like yourself as a physician gets the opportunity to actually address it, I mean, you're saving marriages a lot of the times.
Mhm.
I've seen it
Mhm.
out of our clinics. Now, when we start talking about perimenopause and then we're going into menopause,
Mhm.
right? A lot of these women have issues with sexual health.
Mhm.
So I want to talk about some of these signs and symptoms that are defined as a sexual health issue. It being sexual health dysfunction, even postpartum.
Yeah.
There's urinary incontinence.
Mhm.
Some women have prolapsed uterus.
Mhm.
All of these different things which affect their sexual health.
Correct.
So is that something that you've had the opportunity to specialize in?
Actually, yeah, I'm a fellow of the International Society of Sexual Health and Well-being. So there is, you know, a lot. So there's lots of taboos in women's health. Menopause being the first, that it's not happening, it doesn't happen, and, because if menopause is going on, then you're old and you're done and you're shriveled up, and they're gonna throw you out, and you have nothing to provide society anymore. So that taboo, we've kind of moved past it now. The second taboo is sexual health, where women are like, I'm past that point. I don't really care. I'll do it because I have to, but that isn't okay. And that's a bigger conversation because, again, it also affects the unit, it affects the whole partnership, right?
Right.
Because this is now you're at this point in your life where everything is good. You don't have to worry about getting pregnant anymore. And so you should actually be enjoying it.
Yeah.
And a lot of times they're not due to multiple reasons. One, it could just be neurochemical in the brain, which is the most common hypoactive sexual desire disorder. It's a neurochemical imbalance where you just don't have the desire. Like it is not on the priority list. Physically, you're fine, meaning, and that's how I kind of distinguish it with my patients. I'm like, so once you're in the act and you're involved, are you enjoying it? Oh, yeah, I'm fine then. I just can't go from A to B.
Mm.
So HSDD is the bigger one to treat, and it's harder to treat because it's a neurochemical imbalance in the brain due to estrogen deficiency or fluctuation.
Mm.
The
Okay.
estrogen plays, remember, we have estrogen receptors everywhere from hair, scalp, brain, heart, the vasculature around the heart, bone, skin, vaginal tissue, you name it. We have them everywhere. And so what happens is estrogen declines. In the brain, we have inhibitory and excitatory neurochemicals. The excitatory ones, like your dopamine that makes you happy and gives you pleasure, as well as norepinephrine, are downregulated. And
Mm.
your inhibitory ones are now high. You don't care. You don't care to have sex or not.
Right.
So that is one. Then there is physical changes going on down below, genitourinary syndrome of menopause, where, again, due to the lowered estrogen levels, the vaginal tissue becomes thinned out. There's less lubrication. And so it's not pleasurable and it actually hurts.
Right. Vaginal dryness and there's painful intercourse, right?
Painful
Yeah.
intercourse, exactly. So each one is kind of treated differently. The most important one is really to figure out which one it is and treat it appropriately.
Right.
Testosterone works for some components of it. Vaginal estrogen works for another component, for the atrophy aspect of it. And there's medications such as Vyleesi and Addyi that work on the neurochemical component of it. Addyi just made the headlines again. Addyi, it works directly on those neurochemical pathways. It takes about 8 to 12 weeks for it to work, but then you all of a sudden start just kind of having the desire.
Right.
And it comes back. It was pre-approved, or it was approved for use in premenopausal women for the past 10 years by the FDA. Once again, nobody knew about it.
Is that the Addie's the little
Pink
pink
pill.
pill?
You got it. Yes.
Which one's the PT-141?
Yeah.
Is
Yeah,
okay.
that's Addyi. And so filbastrin, that's the
Okay.
other name of it.
Right.
And then just recently, it was fast-tracked and it passed the FDA for menopausal women as well. So
Okay.
she got the double approval now. And Vyleesi is an on-demand injection that works like kind of like Viagra, where you only use it on demand and you can only use it so many times a month.
Right.
So, and some people can use both. So really, sexual health is a part of female well-being. It's not separate. It's just another, it's kind of like just feeling well like yourself. And it needs to be addressed because a lot of women don't even realize there's a problem until you talk to them about it.
Yeah. So what are some of the things that women can do to
Mhm.
address some of these things? Because on social media you start hearing you got plastic surgeons out there that are
Mhm.
doing things,
Mhm.
for example, like the labiaplasty,
Mhm.
right? Which if a lot of these women that get the labiaplasty, they have painful intercourse
Right.
because of that.
Mhm.
You have people that are doing vaginal rejuvenation. They have different lasers, CO2
Right.
lasers that are, helping getting it more tight,
Mhm.
right? So what are some of the things that you can,
Do to
talk
improve.
about
Yeah.
to improve the sexual health for a woman?
So Now if we're talking about like the vaginal tissue itself and more of a physical problem, there's all different kinds of things. What has been approved and we know works without a doubt is vaginal estrogen cream. Now, somebody has tissue problem or dissensus, or they have a little bit of prolapse or incontinence. I work hand in hand with a pelvic floor therapist who's well specialized in this, and that's all they do all day long. And
Now,
well,
the pelvic floor therapist
yeah,
is someone that is actually helping build up the pelvic muscle.
they do
Okay. Yeah.
exercises with the patient, so it's actually very specific. It used to, I don't know if you remember Kegel exercises where you
Hmm.
just kind of,
Yeah.
you know, contract the pubococcygeal muscles and things like that. That is okay in and of itself, but we've come a lot further
Yeah.
than that. And so the pelvic floor therapist actually will evaluate a patient just like you would evaluate a patient for anything else. And they do dynamic testing and things like that to see what actually is the problem.
Yeah.
Is it too much or is it too relaxed of a tissue? So then they do certain exercises to strengthen those muscles back up, just like you would do a bicep curl to strengthen your biceps and things like that. Or is it a contraction problem? Because some women are just chronically contracted down there. And so it makes it more painful to have intercourse.
Right.
So then they have to release that and then they do better.
Yeah.
And estrogen cream helps because that tissue is dependent on estrogen.
Yeah.
And so it collagenizes it and reepithelializes that tissue. So then it's more pliable. And then it goes back to its baseline.
Yeah, I've even heard that some of these pelvic floor therapists, they will even, especially with patients that
Hmm.
have scar tissue from like
Hmm.
endometriosis, they actually have to go there and actually massage
Correct.
certain areas
Hmm.
to let it
To
relax.
to
Yeah,
break it up,
break it
and
up.
they even do like progressive dilation, and then they self teach that to the patient
Right,
how to use dilators to dilate, because remember the vaginal tissue is very elastic.
right.
So if you can get the dilation up, then you're going to be more
Yeah,
comfortable with intimacy. Now, there are certain lasers that have been used for certain problems down there. And we had the Mona Lisa laser. I was actually trained on it right when it first came out. And we saw a lot of good results with that as well. It's just a laser treatment of the vaginal tissue. And the concept is tightening as well as recollagenization of that
right.
tissue. And it brings it back. After 2, 3 treatments, a patient was like, I can't believe this is working. And then I would add in vaginal estrogen to maintain the progress we've made.
Yeah, these are all great things that we're talking about because I feel we said it at the beginning. Women's health has kind of been neglected
Hmm.
in our society, in our medical system to begin with, and I think there's a lot of women out there that are going through these type of issues and
Hmm.
have these symptoms and don't know what to do, and a lot of them are shy and
Hmm.
hesitant to even bring it up.
Correct.
And I think today's message with what you're saying should give some of these women the opportunity to really kind of think through these things and understand there is solutions to
Hmm.
work through their problems and don't hesitate and ask these questions.
110%, Sam. This is really, I'm not a social media guru or fan whatsoever, but I had to go online because I was seeing it in my office day in and day out with 30, 40 patients a day with the same complaints over and over again.
Right.
So I said to myself, I'm the only one talking about this stuff to these patients. And like you said, they're shy about it. I would literally have to like kind of drag it out of them because they're there for a 15-minute well woman visit with me. And most of the time we check everything good. Yes, yes. Okay, we move on.
Yeah.
And that's when I'd say, okay, no, let me make sure you're okay. And I would start poking. And the more I would ask, the more would come out.
Yeah.
And
Right.
that's when I was like, okay, no, there needs to be more here. I started looking around, and in my community, not a lot of people were talking about this. And
Right.
again, we're in South Florida. There's a lot of providers here, yet I didn't see anybody else saying. So I'm like, okay, I'm just going to take to social media and see what happens. And all it's done is just blown up because women have concerns. And just because my patients know it doesn't mean everybody else knows it.
Right. Right.
So it's word of mouth, spreading the word.
Doc, how if you were to rate hormone optimization for women,
Mhm.
especially when they get into that menopause uh, zone, right? From a scale 1 to 10, 10 being like you really need to consider it,
Mhm.
what would you rate hormone optimization?
I would just rate it an 11. Listen, we're not treating symptoms with hormones. That isn't the goal. The goal isn't just to treat, because I have patients who tell me, Doc, listen, I'm like 55 now. I went through it pretty well. I don't have any symptoms. Why do I need to consider this? We're treating you with hormone therapy, or we should consider it to prevent long term disease. The silent things that are happening internally that you don't know yet, because that heart disease that you're going to have at 65 is starting to happen and develop in your 30s and 40s. And
Right.
as soon as that estrogen level drops, then it starts building up even more. So you start having high blood pressure, high cholesterol, and then at 65, you have a heart attack. So that heart attack could have been prevented had you been on hormones.
That's the truth.
That right? I mean, we know this. The data is there. That hip fracture at 65, that's due to osteopenia and porosis that developed as you went through menopause and didn't get the hormonal support you needed.
Right.
Because estrogen is the only thing we have that not only helps slow down bone breakdown, but it also helps build bone. So that all is part of hormone therapy. So it's not really just for symptom relief of your hot flashes and your mood changes. It's really to prevent you from having chronic disease later. So it's more about having health span and not just lifespan.
Yeah, I love that. And like on the back of the cups, you'll see it there. These are the three things that I always tell people: prevention, early detection, and treatment intervention.
That's right.
When you put the right things in place,
Hmm.
specifically even the treatment intervention, you can get that good health span, not
Exactly.
just lifespan.
Hmm.
So, um, that right now there's a huge movement that's going on, the MAHA movement, Make
Hmm.
America Healthy Again.
Hmm.
What's your thoughts on that?
Well, I think it's about time we've had it. We need to make America healthy again. And in terms of women's health, we've already started that movement because of the black box warning being removed back on November 10th of 2025 after 23 years. I think that was a big step in the right direction to remove that fear base that wasn't there. And so now more women have access to a treatment that could be life saving for them.
Amazing. So we're gonna have a little fun here. We
Okay.
have one of my favorite podcasters, Stephen Bartlett, with the Diary of a CEO. He
Mm-hmm.
came out with these conversation cards.
Oh my gosh.
So
Okay.
I'll let you go ahead and
Oh
open that
boy.
up.
Okay.
You'll grab one card from the inside
Mm-hmm.
somewhere.
Anywhere.
Yeah.
Okay.
Read
Mm-hmm.
it and then answer it.
Oh boy. Okay. Let's see. When do you feel the most emotionally connected to yourself? Oh, I like that. I think I feel the most emotionally connected to myself first thing in the morning when I wake up and I'm having that cup of coffee by myself, nobody else is up. It's typically around 4:35 in the morning. That's why no one else is awake. And I'm getting ready to start my workout and my day.
Nice.
Yeah. That's the best time of day for me.
You feel connected.
Mm-hmm.
Amazing.
Yeah, absolutely.
So, Doc, I want you to take the next couple of minutes here,
Mm-hmm.
and I want this response to come from the heart.
Mm-hmm.
Tell the world what the problem is, right? And the solution that you, as the physician, bring to the table that the world needs to know.
The problem and what's the solution? Okay. I think one of the biggest problems that we have right now is lack of funding for women's health research globally and access to care everywhere. And the solution that I'm a small part of working on with everybody else is to provide more education online on a global scale with a different platform where all of the stuff we just talked about today can be available to anyone anytime they want it. So that way they can go and advocate for themselves and get the best care they deserve.
Amazing. Love that. And Doc, as we start to wrap up here, if there is one person that's
Mhm.
listening to this podcast and truly resonates with today's message, what is that one thing you can leave them off with?
I want you to walk away with knowing that pay attention to the signals your body is giving you. Don't just take everything at face value. Educate yourself and ask questions.
Educate yourself and ask questions.
We give in too easily to, doctor figures thinking they know best for us. And at some point they might. Like if you need a surgical procedure, yeah, they do, they're giving you the right options. But a lot of times we've been trained to just give the easy answer out
All right.
and not really look at the whole overall picture and look at an individual holistically. So really now it's upon the individual to take that upon themselves and find a healthcare provider that's willing to meet them halfway and work with them.
All right. I love that. And Doc, if people want to find you, where can they find you?
I'm all over social media. So on my Instagram at Dr. Jila Senemar, and then my website, jilamd.com.
Amazing.
Mhm.
Dr. Gila, it was a pleasure to have you on a Healthy Point of View podcast. This was very informative, and I appreciate it.
Thank you so much for having me, Sam. It was a great conversation.
Thank you. All right. Guys, you heard Dr. Gila. You got to take control of your own health, right? You can't be dependent on just the bigger bodies to do it. Yes, there's a lot of science behind what we're doing and everything else, but ultimately, if you feel like your body's off, you have to start putting in the work. You have to educate yourself, start researching, start asking questions. There's a lot of experts online that they just want to help people out. Dr. Gila is one of them. She shares tons of information that you might be able to benefit from, but not just you. Even if you're not dealing with something today, there's probably someone in your Rolodex, someone in your following on social media that can benefit from today's message. So if you know someone, make sure you share this podcast. Make sure you like it, comment, do all that fun stuff, and we'll see you for the next one.